Hello guys, welcome to our channel. Today we are going to have the rapid revision of the internal medicine. In this, I have made into the two parts. Part one will be your neurology and the respiratory system, and the part two will be cardiology, endocrinology, and the nephrology. So this is a very high yield and very scoring subject in your paper two. So don't miss out to watch two parts and have the revision and the MCQ practice. So before we start, please do subscribe and share with your friends. So let's start our discussion with the neurology. So first, we are going to discuss about the three different types of the headaches, which is very, very most common. So first one is your tension. So as of now, you have to understand that the only high yield points about the headache is the most common of overall all the headaches is the tension headache. And the migraine is the second most common, and the cluster is the rare but third most common. So, but there is a question once it is asked in the examination. Overall, what is the most common cause of the headache? Is it the secondary or is it the primary? So, what we are discussing here, these are the primary headaches. Okay, but the question is in the options there is also mentioned the secondary cause also. So, remember that the most common overall is your secondary only. So, the secondary headache is most common cause. And in that secondary headache, what is the cause of that? Acute febrile illness. Okay, so you may also have this kind of headaches. Like whenever you have the fever, you will be experiencing the headache, right? That is what the secondary cause of the headache, which is most common overall. And coming to the primary causes, here you can see the tension, migraine, and the cluster. So let's understand by the age or by the presentation and also associated symptoms. Whenever I say tension headache is usually common in the females than males. Same as the migraine, we all know that females have the more prone to migraine history than the male patients. But unlike that, your cluster headache is more common in the males than the females. And in the tension headache, the most commonly the patients will be having the other aggravating symptoms. For such as patient might be having the diverse, patient might be having the stress, and patient family issues, economical issues, all this will be having the contributing factors for the tension headache. And how they are going to present it, the patients usually having these kind of symptoms like 72 hours or more than 72 hours, they will be presentation, and these patients will be having the throbbing kind of headache. Okay, in the example in the picture also here you can see like band shaped headache or the throbbing headache in the frontal region. So this is what happening in the patients, and it is always bilateral throbbing and band like headache. Okay, this is how the patient also going to explain to us. And next, coming to the migraine headache. Migraine headache is always unilateral. Okay, and how this is going to present it? This will be presented as a classic type, and other one is the non-classic type. So what I mean by classic type? So classic type means the patient will be having the aura. So if the aura is presented, the patient will be having the classic migraine headache. What is the aura? In this aura, patient will be having the photophobia, and also there will be nausea and vomiting. This is what the classic headache. And other one is the non-classic headache. The aura is absent in this patient. And in this, which is the most common, then again you have to say your non-classical type is the most common presentation of the patient. And there will be a pulsatile pain. Okay, the pain will be like pulsatile, like steady and sudden, like sharp, like this pain will be continuous pain. Instead of the continuous pain, the pain will be pulsatile, sudden. This way, the patient will be having. And this is also more than 72 hours only. All right. Next, coming to the cluster headache. Cluster headache will be only on the particular region. Very unilateral situation, and the patient will be having the headache at the retroorbital pain, or patient will be having the pain on this side. This is what the how patient will be presented with the cluster. And associated symptom, this patient will be having the lacrimation. Okay, if it is in the orbital region, the patient will be having the tearing sensation or the redness of the eyes, and even congestion is also sometimes seen in this patient. And this is usually not more than 4 to 5 hours. Okay, 5 to 6 hours is the headache presentation. And what about the therapy? So there is a acute therapy, and there is also a drug of the choice. And how can we prevent this headaches? When I say tension headache, your drug of the choice is always NSAIDs. Okay, like you can give the acetaminophen or the ibuprofen. These drugs can be given. And what about the patients, those who are coming from the migraine in the first attack? In the initial attack, what we can give for this patient, like if it is a less symptomatic, the patient will be having only the acute stages, we can go for the NSAIDs. Same like that, we can start on the patient on the naproxen or the ibuprofen. These drugs can be given. But ultimate for this patient, what is the drug of the choice? That is your sumatriptan. This is the only drug that we can give for this patient. But sumatriptan have its own cons. And what are those? It is contraindicated in the patients with the heart disease. It is contraindicated in the patients with the kidney disease. So we are never going to start the patient with a sumatriptan with these comorbs. And cluster headache, the treatment for this cluster headache is the oxygen therapy. Okay, immediately when the patient is having this presentation, you have to give 6 to 12 liters of the oxygen. You can give for 1 hour or the 15 minutes can be fine. Okay, 15 to 60 minutes oxygen therapy is fine for this patient presentation. And coming to the prevention. Prevention is like prophylaxis for this patient. So the prophylaxis for the patient, those who are suffering from the tension headache, is your antidepressants. Okay, in the antidepressants, your drug of the choice is amitriptyline. Okay, amitriptyline for the 6 weeks you can start on this patient. Okay, that is what, because what we see in here, the patient is having the other side effects, right? Like he was having the diverse situation, stress, family. So this is likely to be having the low serotonin. So to increase that and to decrease the symptoms, what we can give, antidepressants can be the good choice of the prevention. Next, coming to the migraine. In the migraine, you all know the drug of the choice for the patients, those who are suffering from the migraine, your propranolol. Okay, propranolol is the drug of the choice for the migraine prophylaxis. Along with that, you can also give the other drugs like your topiramate can be given. Okay, your topiramate can be given for this patient, and also you can give the verapamil and ergot alkaloids. But ergot alkaloids is not giving nowadays because of its gangrene formation, and some other drugs can be also given for this patient's migraine prophylaxis. And in the cluster, the prophylaxis drug of the choice is steroids. Okay, the patient can be tapering with the tapering of the doses. You can start on the steroids. So this is what the difference between the tension migraine and the cluster headache. And next, moving on to our next topic, that is your aphasia. So here in this picture, you can see we are going to discuss about the Wernicke's area and the Broca's area. So Broca's aphasia is non-fluent aphasia. So what does mean by the non-fluent aphasia of this patient? So the patient, whenever we are asking this patient with the like what is the presentation of the symptoms, when we are checking the GCS score of this patient, the patient's speech is always broken and there will be a in between pauses, and also it is slow speech. So this is what the meaning by non-fluent speech. When I say Wernicke's aphasia, this is fluent aphasia. Okay, in this fluent aphasia, the patient comprehension. So the patient formation of the words speaking is very good, but it is not understandable by us. So this is what the fluent aphasia. So new words will be used by this patient, and good speech is seen. Okay, it is fluent. Good fluency is also seen in this patient. All this, but non-coherent speech is heard in this patient. This is what the Wernicke's aphasia. And Broca's aphasia is always associated with the motor symptoms, such as the patient might be having the paralysis, tongue paralysis, or the lower limb paralysis. All this will be associated with the Broca's. Wernicke's is no motor symptoms will be presented. Okay, no motor symptoms. And Brodmann's area is also commonly asked question. So when I say the Broca's aphasia, its Brodmann's area is 44 and 45. This is what Broca's. And for the Wernicke's, it is 22. Okay, at least you can remember 44 for the Broca's, 22 for the Wernicke's. And how about the the arterial supply for this Broca's area and the Wernicke's area? Here there will be a MCA, right? So this MCA, the superior branch, is going to supply for your Broca's aphasia, and the inferior MCA is going to supply for the Wernicke's. So the inferior MCA is for your Wernicke's and the superior MCA for Broca's aphasia. So most common, whenever the question is coming from the most common aphasia overall is the anomic aphasia. Okay, it is anomic aphasia. Why this anomic aphasia is seen in these patients? Because the patient, you may have seen in the multiple movies, the patient post-trauma, he may be forgetting his relatives, he may be forgetting his lover. All this will be seen, right? That is what. So the post-traumatic, the patient will be having the anomic aphasia. And in this, especially the naming is not formed by the, not recognized or not mostly affected in the patient presentation. Now let's discuss the trauma of the subdural hematoma and the epidural hematoma. Okay, so here you can see this is your subdural hematoma. Okay, this is your epidural hematoma and here the subdural hematoma. How these patients are going to present it? So the patients, those who are suffered from the trauma in the acute situations. So first the patient will be having the loss of consciousness. Okay, this patient will be having the loss of consciousness, and again he will regain this loss of consciousness. Again he will be going back to the loss of consciousness. What is this specific phenomena? This is known as your lucid phenomena. And this lucid interval, this is seen in only these patients that is suffering from the epidural hematoma. And what is the artery that is involved in this patient? Middle meningeal artery. This is the middle meningeal artery that is coming from your foramen spinosum, that is involved here, and only the arterial blood is pooling here. And how this is presented? This is presented as a biconvex shape in the, like you are here, you can see this is your non-contrast CT scan. And next coming to the subdural hematoma, and it is sickle shape. Okay, S for subdural, S for sickle shape. And this is patients usually alcoholics and patients those who are having the trauma can be also present. But it is not in the acute presentation and no lucid interval is seen in this patient. Okay, no lucid interval is seen. Even Hrithik Roshan is also once suffered this in his shooting spot, and it is went until chronic stages also. So this can be presented even in the chronic stages more than 12 weeks. So this is what your subdural, and subdural is involves the only venous plexus. Okay, this will involve the venous plexus. This is what difference, main difference between your EDH and the SDH questions. Next, moving on to our stroke protocol. Whenever we say the stroke can be two types. Okay, one is your hemorrhagic stroke and another one is the ischemic strokes. Ischemic strokes are based on the thrombus or the embolic stroke only. So the artery is intact, only the blockage is in the circulation. This is what causing the ischemia because the circulation is poor and the tissue damage is high. And the hemorrhagic strokes are only due to the subarachnoid hemorrhage due to aneurysm ruptures. All this will be. So the wall of the artery is already ruptured and this is leaking into the inside of the sulcus or the gyri of the cerebrum. That is what happening in this patient. And also the main type, the majority of the patients will be having the TIA. What is this TIA? The transient ischemic attack. How these patients will be presented? Basically, this patient will be having the loss of consciousness or the syncope, sudden loss of consciousness, and only the symptoms will be neurological deficits. Okay, the patient might be having the sudden onset of the slurred speech. These kind of symptoms will be presented, and the photophobia, this is present. And whenever we say TIA, it is only less than 24 hours. Okay, neurological deficits, loss of consciousness, and loss of consciousness less than 2 hours, 24 hours, that is your transient ischemic attack. And when you do the imaging for this patient, and in the imaging now, it will be always normal only. That is what happening. And you have to treat with the dual antiplatelets. Why we have to treat the dual antiplatelets? Because there is no ischemia or the no hemorrhagic in this patient. But this is a signal there is a high chance of the stroke in the next 1 week or the next 1 month. So that's why we have to treat these patients on the dual antiplatelets. And when I say the hemorrhagic stroke, that is most common location is the putamen. Okay, most common location is the putamen, and most common artery is also involved with the MCA territory. And even in the ischemia also, the most common is the MCA territory. The middle cerebral artery is involved in this patients. All right. Next, coming to the embolic stroke. And if I say embolic stroke, the most common cause is the atrial fibrillation. This can be the severe cause for the sudden onset of the ischemia and also the patient with the cardiac disease. Okay. When I say risk factors, it can be the modifiable and the non-modifiable. So modifiable risk factors will be your smoking, okay, hypertension, and the diabetes mellitus. And non-modifiable patient genetics and patient age, right? These are your modifiable, non-modifiable risk factors. And how we are going to understand this patient immediately. So you have to know this score. This is a common score that is used by the WHO. Be fast. What does mean by the be fast? Whenever you see the patient's symptoms, is he having the any loss of balance or the headache, sudden onset of the dizziness? Blurred vision, is the patient having the any eye difficulties? The patient is having the any kind of the ophthalmic symptoms like nystagmus or the blurred vision that can be alerted, and the facial drop, facial paralysis, or the arm weakness, or the like unilateral side or the bilateral side, any hemiplegia or the diplegia is presented in this patient. Slurred speech, or the patient is having the sudden onset of the speech difficulty. What we have discussed earlier, the aphasias, Broca's aphasia or the Wernicke's aphasia, and all the consideration of all these, you have to time to call for the ambulance or the emergency care to treat this patient as soon as possible. This is the one of the score that is protocol can be used. And another one is the ABCD2. What is this ABCD2? A for patient age more than 60 years of the age, or the patient is having the more than 140 by 100 mmHg, or patient is having the blood pressure, this onset, or the patient is having the sudden onset of the hemiplegia. This can be considered to be okay, or the patient is having the any neurological focal symptoms, or patient is having the diabetes mellitus, and what is the duration of this presentation. Okay, duration, why duration is important, we will be understanding the treatment protocol. So always, let's say the patient is presented with the ischemia stroke, what you have to do it now. So the patient is having the slurred speech, and the patient is also having the weakness. So based on this, you have to go for the NCCT. So this is your first line of the diagnostic test. Okay, go and do the NCCT. If you see the NCCT bleed, okay, your differential diagnosis is this epidural hematoma, subdural hematoma, or the subarachnoid hemorrhage. You have to rule out. Or if it is no bleed, the patient is not having the any kind of the bleed, then you can go for the diffusion weighted MRI along with the angiogram. Okay, cerebral angiogram is the most preferred one in the no bleed of this patient. And if you see the patient is presented less than 4.5 hours, then you can go for this patient with the thrombolysis. Thrombolysis, drug of the choice can be streptokinase or the ATPase or the tenecteplase. This drug can be used for the streptokinase prophylaxis. This is what less than 4.5 hours. And if the patient is more than 4.5 hours, then you have to treat this patient as a conservative only. So if you do the patient any treatment with a thrombolysis more than 4.5 hours, still no improvement. That's why you have to go for the conservative treatment for this patient. But thrombolysis having its own cons and the pros. For that, the thrombolysis is only done for the patient, those who are suffering, like patient should be less than 4.5 hours, patient should be more than 18 years of old, and no active bleeding. Okay, no active bleeding should be presented, and no cerebral edema. Only all these can be considered and moved for the patient of the thrombolysis. And what are the contraindications for the thrombolysis? You never do the thrombolysis in the patients those who are suffering from the ischemic heart disease, or patients those who have the history of the CKD or the continuous liver disease, cirrhosis, alcoholic liver disease. You are never going to do. Recent GI bleed is present in this patient. Peptic ulcer disease is presented, or patient is having the menstrual issues, currently menstrual issues, hemophilia patients. These all conditions, we are not going to do the present thrombolysis. And patient, if he is having the hypertension emergency, what does mean by the hypertension emergency? More than 185 by more than 110 mmHg. In these situations also, we are not going to proceed for the thrombolysis. And there is a mechanical thrombectomy can be done. For this mechanical thrombectomy, we have to consider this patient less than 6 hours, and it is only going to involve the 1/3 of the MCA table. Okay, the ischemia should be less than 6 hours and 1/3 of the MCA territory involved. Then you can go for the mechanical thrombectomy. Okay, this is what the treatment protocol for the all the diseases of the all the stroke presentations. Okay, next here the small topic that we will discuss here, movement disorders. Okay, movement disorders. And in this movement disorders, where is the location and what kind of movement disorder is present? So caudate nucleus. In the caudate nucleus, the patient will be having the chorea-like symptoms. Okay, Huntington's chorea or the Sydenham's chorea, all this will be due to caudate nucleus. And next, putamen. Putamen will be presented as the ethetosis. Next, balismus. This is seen in your subthalamus. In the subthalamus, the patient will be having the balismus. Okay, tremors. Tremors are basically seen in the extrapyramidal symptoms. Okay, extrapyramidal system, you are going to having this condition. And next, rest tremor. Specifically, the rest tremor is also again your basal ganglia, and mostly this is seen in the Parkinson's patients. Intention tremor. Intention tremor is seen due to cerebellum lesions. Posture tremor. Postural tremor. This postural tremor is seen due to hysteresis. Postural tremor is seen in the hysteresis. And the flapping tremor is seen in the hepatic encephalopathy. Okay, all these are very, very important for the movement disorders and their locations. Next, we will be discussing the neuromuscular disorders. In the neuromuscular disorders, here you can see in this picture, one patient is presented with the Lambert-Eaton syndrome, other one is the myasthenia gravis, and they both had the lamb for the dinner. Let's see what is the difference. So let's say this is the dinner time. These two patients is presented for the have the dinner. So the Lambert-Eaton patient is very active to start his dinner. But when you see the myasthenia gravis patient, she is a woman and she cannot enjoy the dinner. Why? And here in this picture itself, you can understand the difference. Basically, Lambert-Eaton syndrome is affected in the patients, those who are males. Why in the males? This is mostly associated with your lung cancers. Okay, so the small cell lung cancer, it will be presented in the males due to smoking risk factor, and this is seen with the as a paraneoplastic syndrome. Next, coming to the myasthenia gravis, it is an autoimmune condition. Mostly the females will be affected. That is the major difference that you can observe. And in the myasthenia gravis, the patient's morning will be active. Okay, by the time they come into the evening, all the acetylcholine will be already gone. So they will be inactive in the later on stages. And whereas your Lambert-Eaton syndrome patients, the defect is not in the acetylcholine, the defect is in the calcium channels. Okay, the voltage gated calcium channel, the problem is here. So in the morning, they will start their morning as a inactive, but by the time in the evening, this patient will be having the active. This is what the diurnal variation between the Lambert-Eaton syndrome and the myasthenia gravis. Okay, so the small cell lung cancer will be seen in the Lambert-Eaton patients. The myasthenia gravis patient, we all know that thymoma or the thymic hyperplasia is seen in the myasthenia gravis patient. So let's understand, only the main goal is to understand the myasthenia gravis only, because Lambert-Eaton is very rarely asked, and associated condition, small cell lung carcinoma. Okay, so myasthenia gravis condition is an autoimmune condition and it is a chronic condition. All right, and it will involve the neuromuscular junction basically. This patient is also known for the type 2 hypersensitivity reactions. Usually, this is going to involve the females more than the males. All your autoimmune conditions is mostly females than the males. Okay, and if the males is involved in the younger age, now this patient will be having the very poor symptoms. Okay, poor symptoms, like symptoms will be very less and the prognosis is good. Whereas females in the young age having the poor prognosis. And when the patient old female will be having the good prognosis. Okay, and the male patients, those who are old men, this will be having the poor prognosis. So this variation is also found in the myasthenia gravis patient. And mostly in the myasthenia gravis, the most involved antibody is the anti-acetylcholine antibodies. Okay, this is the most common one. Second most common is your anti-musk agents. This is your second most common. So this is your seropositive and this is your seronegative. Okay, and how these patients are going to present it? Common symptom is the ptosis, and this ptosis will involve the levator muscle. Okay, levator palpebral muscle. Okay, this is the most common involved one. And this ptosis will be progressive to the patient will be having the double vision. And if this double vision after the involving these muscles, this is going to progress to the proximal muscles. Okay, always this patient will be having the weakness, okay, tired, fatigue, diurnal variation, all this will be going to present in this patient. All right. Next, after all this, it is going to involve the facial. This is almost the chronic stage of the patient. In this chronic stage, very severe will be presentation of the patient. Continuously, the patient will be having the tiredness, and these kind of phases is known as the snoring phases. Snoring phases is seen in the myasthenia gravis patient. Coming to the diagnostic test, the most sensitive one is your single nerve test. Okay, single nerve test is your most sensitive and most specific. When I say most specific, the test is the antibodies test. Okay, if the antibodies is positive, then that is your most specific only. And what is the other specific test we are going to perform in this patient? That is your tensilon test, right? Remember, you are going to inject this patient with the hydrophonium. Okay, this is what we are going to give for this patient. What is the drug of the choice for the myasthenia gravis? Yesterday we discussed in the pharmacology, pyridostigmine. And you can do the thymectomy to decrease the symptoms progression. This is what your myasthenia gravis overview. Next, moving on to the GBS. So GBS is a condition that is seen in the patients, those who are sudden onset. This is sudden onset, and it is also associated with the autoimmune acute condition. Along with the patient will be having the history of the diarrhea. Basically, this is due to your GI intestinal system only. That is due to Campylobacter, influenza virus, rotavirus, even COVID-19 patients also have this GBS syndromes attacks. What is this GBS syndromes? This is an ascending paralysis condition. Okay, over the time, very acute stage, this patient will be affected. What are the causative agents? As we already discussed, that is your Campylobacter. Only the viruses or the bacterial agents who is having this condition will be affected. And in this patient, how the symptoms, the ascending paralysis will be starting. Like your flaccid paralysis, the patient will be having all the reflexes will be down, and patient will be, the symptoms also progressive over the time. And the question commonly asked is the bowel and the bladder will be involved in the acute stages. These are the very late symptoms. Okay, these are late symptoms presented in these patients. Only the lower motor neuron will be involved. Lower motor neurons will be involved in this patient. And there are some types also. And your symptoms like GBS will be different types. They are like Aman. Okay, this is only for the motor. Your Amsan, motor plus sensory. Okay, and third type is your AIDP. Okay, this is your polyneuropathy. Multiple nerves are involved in this patient. And the last one, least common, very severe one, that is your Miller-Fisher syndrome. Okay, very rare but very severe also. These are the 3-4 types of your GBS. And what are the antibodies that is present in the Aman, Amsan, and the AIDP? This is most common in the India. Okay, remember, AIDP is most common in the India. And this both will be having the ADP. Sorry, anti-GD1 antibodies. This is the most commonly involved anti-GD1 antibodies. And whatever the our most common Indian type, that will be involved the anti-GM. Anti-GM1 is the most common in the Indian type. And this is having the anti-GQ. Okay, anti-GQ in the Miller-Fisher type. And what is the treatment? The treatment is always IVIG or the plasmapheresis. This is the treatment of the choice. Usually patient will be given the 4 weeks. In these 4 weeks, if the IVIG and the plasmapheresis work, the patient will be cured. Or else the patient will be having the death due to respiratory paralysis. Okay, respiratory paralysis will be attacked and patient will be died. And what is the criteria? The criteria can be asked. You don't have to know the criteria. So the Britton's criteria used for this patient. Okay, Britton's criteria used for this patient. Next, moving on to the next type, that is your CNS diseases like demyelinating diseases, multiple sclerosis, and patients those who are suffering from the MOG syndrome, you may have. This is also one of the demyelinating syndrome, and neuromyelitis optica. Okay, neuromyelitis optica. So these three differences you should understand. So myasthenia gravis is also an autoimmune condition. In this, your anti-MBP antibodies is involved. And in the MOG syndrome, anti-myelin oligodendrocytes. Okay, anti-myelin oligodendrocytes. This is your myelin oligodendrocytes antibodies is present in the MOG syndrome. And in the neuromyelitis, anti-IQ antibodies is involved in the neuromyelitis. And only the thing that you have to remember, this patient will be having the optic neuritis, spinal segments is involved. Okay, all are three only. Three commonly, spinal is involved, and also optic neuritis is common condition. In the spinal segments of the myasthenia gravis, less than 3 segments only involved. And same with that, MOG syndrome also, less than 3 segments of the spinal is involved. Whereas your neuromyelitis optica, this is going to involve the more than 3 segments. Okay, and the myasthenia gravis unilateral optic neuritis. Your MOG syndrome will be bilateral optic neuritis, and your neuromyelitis optica is also bilateral optic neuritis. So this is what the major difference between the myasthenia gravis, the neuromyelitis optica, and MOG syndrome. And what is the best prognosis overall? So the best prognosis is this MOG syndrome, very poor and severe prognosis is for the neuromyelitis, and moderate for your multiple sclerosis. And in the multiple sclerosis, what is the criteria? This is also asked. M for myasthenia, M for multiple sclerosis, M for McDonald. McDonald criteria is used for this patient. Okay, this is what your major multiple syndromes all we have completed the discussion. And the next one or the last one, you have to understand the difference between these conditions. What is this sign, guys? This is your Gower sign. And the patient is also having the calf muscles pseudo hypertrophy. In which condition you are going to see? This is your Duchenne muscular dystrophy. Why? This is due to dystrophin gene absence. Completely the gene is absent in this patient. And this is what kind of condition is this? This is a X-linked recessive. Okay, this is your X-linked recessive condition, and other type also presented. If the complete absence, that we know as the DMD, Duchenne muscular dystrophy. But let's say this is only the dystrophin is in the low levels. If the dystrophin is in the low levels, then we have to call this as a DMD, Becker muscular dystrophy. And this patient will be having the poor prognosis because complete absence, very early paralysis is seen in this patient. If the patient, the dystrophin is also not present, so the cardiac muscle is also going to involve. Dilated cardiomyopathy is seen, and early age of death. Okay, less than 20 years only this patient going to die. Dystrophin is only less amounts, right? This will also involve the cardiac myopathy. But this patient will be having the better prognosis comparing to the DMD patients. And what is the best test that is we can do? Gold standard for this patient is the CKMB. And CKMB elevated more than 2K. Okay, 1 to 2K. And usually we are going to having only 200 to 300 only. And if it is more than 2K, then you have to think that is your Duchenne muscular dystrophy. Now let's start with the respiratory system. In this respiratory system, the presentation of the bronchioles, how this is we have to understand. Here you can see the patient is normal airway. There is no bronchoconstriction. When you see the asthmatic airway, it is completely constricted and patient is hardly able to exhale his breath from the inhalation. So how this patient going to present it and what are the causes we will be seeing. So asthma, when I say asthma, this is most commonly seen in the children's. Okay, pediatric patient highly present with the asthmatic attacks. And in these patients also, this is due to extrinsic factors. What are those extrinsic? Like atopy, the patient will be having the history of the family history atopy, and due to IgE antibodies. And also patient will be having the classic type 1 of the presentation in the asthma in the children's. And this is always good prognosis. Whenever we start early time now, this patient will be having the good prognosis. All right. So in the adult asthma, there are two types. In the adult asthma, there are two types. Type 2 asthma, non-type 2 asthma. What is this non-type 2 and the type 2? So type 2 is basically on the eosinophils. And this is kind of allergic. And when I say non-type 2, this is usually your neutrophils. What are the T helper cells? In the eosinophils, T helper 2 is going to involve. Here T helper 1 and T helper 17 is going to involve here. And what are the allergens? When I say allergens, your eosinophils, right? Eosinophils is the major one and also B cells are the major one. For this, the activation, you need the interleukins. You need the interleukin 5 and interleukin for the activation of this allergic type. And this is the most common type. And this is rare but very severe condition. For these patients now, what are the interleukins? Interleukin 17 is going to involve, interleukin 6 is going to involve, and interleukin 1. All this will be activate your neutrophils. This is the two types of the asthma. And how to confirm the asthma patients? What are the diagnostic tests that we have to do? In the diagnostic test, the gold standard is your spirometry. Okay, so the gold standard will be spirometry and the pulmonary function test. In the pulmonary function test, we are going to check the forced exhalation of this patient. When I say forced exhalation, in the first 1 second, this patient will be giving the less than 0.7 to 70% of the bronchodilation. So then I give the SAMA, your salbutamol or your short-acting muscarinic antagonist. If I give this drug now, after the sometime, this patient will be having the more than 12%. So what you have observed, so less than 70%, less than 7% to more than 12%. This is what the reversibility. Okay. So only condition, the only obstructive lung disease showing the post bronchodilation reversibility that is seen in the patients, those who are suffering from the asthma. And if I give the same this drug in the COPD patient, I don't see the reversibility. That is your chronic obstructive and damaged emphysema will be having that condition. All right. And coming to the treatment. Universally, for these patients, if you want to treat these patients, we have to follow the GINA guidelines. In this GINA guidelines, if the patient is having the more than 4 or equal to 4 attacks per week, or the patient is having the more than 1 episode in the 1 night, any 1 night in the 1 week, more than 1 episode also, then we have to consider this patient is having the very severe condition of the asthma. And based on this, if the patient post bronchodilation is improved more than 30%, okay, what we have seen here, more than 12%, right? But if you are giving the bronchodilation, the pulmonary function test is more than 30%, then you can continue on the low dose only. What is the low dose? LABA, okay? Your long-acting broncho agonist, okay? And you can start on the inhalation corticosteroids. And SOS, this patient can be given the SABA. Okay, emergency situations, you can give the SABA. This is what the low dose protocol for the more than 30%. And next, see other patient having the same symptoms, but this patient is having the poor prognosis, less than 30%. Then you have to start on the medium LABA plus ICS. And again, on and off SABA for the acute attacks. And if the patient is not improving, then go for the double dose or the next dose. What is this pattern? Step ladder pattern. So here you can understand. First, we have started in the low dose. It is not controlling. Then on the medium, and then again on the double. This is also known as the step ladder pattern used in the GINA guidelines of the asthma. Okay. Next, moving on to the COPD patients. COPD patients, we all know this is a chronic obstructive pulmonary disease. Why this patient is having this condition? What is the most common risk factor? Smoking. And females also affected in this condition. For the females, especially in the India, villages, rural regions, biofuel mass. This is the culprits of the chronic obstructive pulmonary disease. How this is going to presented? This is presented in the two types. One is the bronchitis, other one is the emphysema. The bronchitis, the patient will be having the more than 2 years and continuously more than or equal to 3 months. Okay, this is how the chronic bronchitis, dry cough will be presented in this patient. Okay, and emphysema patient, complete dilatation. Okay, the airway is collapsed. This is what chronic dilatation of the acne, irreversible dilatation. Okay, irreversible dilatation is seen. There are some types. One is your central type. Okay, and other one is your pan-acinar and preseptal. Okay, these are the three types. So the central is the most common, pan-acinar is the second most common, and this is rare. So your central one will be mostly due to smoke, and pan-acinar is your alpha antitrypsin disease. Okay, this is a genetic autosomal recessive condition, and the preseptal is also due to smoking. What are the lungs will be involved? Lung lobes. Usually your central will be involves the upper lobe, and pan-acinar is going to involve the lower lobe, and the preseptal will be also going to involve the lower. And the preseptal will be causing the pneumothorax. Okay, sudden onset with the pneumothorax can be in the patients with the preseptal emphysema also. Okay, this is what. And also commonly asked question, in the COPD patients, if the patient is having the death, what is the cause of death? This is always due to coronary artery disease. Okay, this is the common cause. Never think that the patient is having the respiratory failure and death. This is due to coronary artery disease. All right, this is what. So next, coming to the test, again we are going to do the pulmonary function test. In this, the patient, what we say did for the patients of the asthma, you are going to do the pulmonary function test. You are going to check. Still, the patient will be also having the chronic obstructive, right? This will be also having the 70% only. And you given the LABA or SABA for this patient, post bronchodilation, and again you are going to check, it's still 0.7% only, or it's still 20% only. Then that means it is no reversibility. So the damage is already done. Here, what we said is an irreversible dilatation. That's what the COPD patients. All right. And what is the criteria we are going to use? That is your GOLD criteria. Based on these criteria, now we have to start the patient on the treatment of the patient. And how we are going to treat this patient? Basically, we are going to use again the GINA guidelines only. In the GINA guidelines, we are going to start this patient treatment. Okay. LAMA, long-active muscarinic antagonist, or the long-active bronchodilators we are going to use for this patient. And what is the ultimate treatment for this patient? O2 therapy. Okay, ultimate treatment for this patient, O2 therapy more than 14 hours per day, more than 14 to 16 hours per day is the treatment of the choice for the improvement, for the lifestyle improvement of these patients. Unless or until we cannot treat this patient normally. Okay, so treatment protocol for the COPD patients, you have to see whether the patient is having the more than 2 episodes in the last 1 year of the medical consult for his attacks. Okay, or the patient is having the more than 1 episode or equal to 1 episode, needed the hospital admission or the mechanical ventilation is needed for this patient. Based on these classification, we are going to treat this patient if it is yes or if it is no. If it is no, you can still continue for the patients on the based on their clinical grading. So grade 1 to 0, grade 1 or the grade 2. If it is the patient is in the grade 1, then you can go for the LAMA. If the patient is in the grade 2, LAMA plus LABA. If the patient is S, then this is your category category E, and this patient will be needing the LAMA plus LABA high dose. This is what the treatment protocol for the COPD. Next topic is the respiratory failure. So respiratory failure is subdivided into the two types. What is this one, guys? Type 1 is the most common one. Okay. Type 1 is the most common one. Type 2 is the second most common. We have only type 2, type 1. But nowadays there is also new discovery of the type 3 and type 4 also. And basically in the type 1 patient, it is always hypoxic condition. And most common in the type 1 is pneumonia. This is the most deadly one that is associated in the patients of the respiratory failure. And treatment of the choice for this patient is the oxygen therapy, because the main cause is the hypoxia, right? That's why you have to treat this patient with the O2 therapy. And type 2, these patients will be having the hypercarbic, and sometimes when you see the PaO2 is normal only. So only the PCO2 will be high. And most common cause for this patient is the COPD. COPD patients will be presented this way. And treatment for this patient, O2 therapy, you have to give still. And along with that, you have to do the non-invasive ventilation. Okay, non-invasive ventilation. Better one, which is your BPAP. That is the treatment protocol for the respiratory failure. And as I said, type 3 is also presented and type 4 is also presented. What is the type 3, guys? Usually the type 3 is seen in the post-operative phases. When the patient is having the anesthesia for any reasons, in the post-operative ward, the patient will be having the type 3. For these patients now, you have to treat with the spirometer. Spirometer is the treatment. Type 4 is seen in the patients, those who are suffering from the sepsis. Okay, sepsis patients or the shock, any kind of the neurogenic, cardiogenic patients, this patient will be having the shock symptoms due to hyperperfusion to the organs. For this patient, you have to treat with the non-invasive ventilation only. CPAP, BiPAP can be given for this patient. Next, so ARDS is the non-cardiogenic pulmonary edema. This is not due to the any cardiac pathology. This is the your next one is the ARDS. What is the ARDS? Acute respiratory distress syndrome. This is the non-cardiogenic. Okay, this is not related to your cardiac pathology, pulmonary edema. And this will be associated with the type 1 respiratory failure, most commonly due to pneumonia. And we have seen this Berlin's criteria. This is known as the Berlin's criteria. This can be asked as your question. What is the Berlin's criteria? The most one is the SpO2. We have to know the PaO2 values of this patient. So if it is in a mild, this will be in the less than 100. If it is moderate, then 100 to 200. If it is more than 200, that is the severe hypoxia that the patient might be having. And what is the other criteria? Radiological features. The patient should be having the bilateral infiltrates, and that should be explained the pleural effusion or the epichlosis. This patient should be ruled out of the cardiac cause. The pulmonary edema that the patient is having is not due to the cardiogenic. That should be maintained. And the symptoms should be less than 7 days only. This is what all the criteria should be fulfilled in the Berlin's criteria. All right, this is you are going to follow the protocol. What is the treatment then? The treatment is always mechanical ventilation. You have to start the patient on the mechanical ventilation with the settings of the tidal volume should be less than 6 ml per kg. Okay, less than 6 ml per kg. And patient PEEP. So this PEEP value should be high. Okay, PEEP value should be high. Tidal volume should be low. And the FiO2 is always less than 60%. Better positions can be done, like your prone positions is advised. And if the mechanical ventilation is not suitable patient, then you have to change this patient for the ECMO. Okay, ECMO is only the final choice to treat these patients. Next one is your idiopathic pulmonary edema. Restrictive diseases, right? In these restrictive conditions, we are going to discuss the idiopathic pulmonary fibrosis. This is the most common type of the restrictive disease. When we see these patients, usually 50 years of the old, mostly male patients will be presented. History of the genetic diseases And also smoking is the common factor that is found in this patient. And what type of symptoms will be seen? The patient will be having the well-pro crackles. Okay, this is the common features of the restrictive idiopathic pulmonary edema. Along with that, you will be having the crepitus. On the auscultation, these two will be common finding. And the investigation of the choice for this patient is the HRCT. Or the HRCT will be showing the specific pattern like bronchiectasis changes is seen in this patient, and along with that honeycomb pattern. This is commonly seen in the lung fibrosis of this patient. And the treatment, you have to give the antifibrotics. The drug of the choice for this patient is the nintedanib. This is the monoclonal antibody antifibrotic agent. Along with that, you have to give the immunosuppressants. Okay, this is what your idiopathic pulmonary edema. And we are not going to end up, the best treatment for this patient is the lung transplantation. We all know that sarcoidosis is again autoimmune condition, and the cause of the sarcoidosis is always idiopathic only. Very rarely this patient will be having the other causes, but most common is the idiopathic condition only. And this will be presented as a non-caseous granulomatous disease. Okay, non-caseous granulomatous. The most commonly involved organ is the lung along with the skin. And this is the classic presentation. The patient will be having the bilateral lymphadenopathy, hilar lymphadenopathy, along with that the skin lesions. What is the skin lesion? Erythema nodosum. And this is your bilateral hilar lymphadenopathy. Okay, this is what the common presentation of the patients, those who are suffering from the sarcoidosis. And what is this staging, guys? This staging is known as the scadding staging. What is the scadding staging? In the stage 1, the patient will be having this kind of bilateral hilar lymphadenopathy, but normal lung parenchyma. Over the time, if this hilar lymphadenopathy is aggravated, the patient will be also having the infiltrates. Okay, the infiltration is also seen. Along with the infiltration, but the lymphadenopathy is already gone. Here you can see the lymphadenopathy is prominent. But in the third stage, no lymphadenopathy is seen. Over the time, the progression can be done, and this patient will be having the irreversible damage of the lung fibrosis. Okay, that is what the presentation of this patient. And cough, the common symptoms of this patient will be cough, fever, weight loss. All this will be presented same as your TB. But when you do the biopsy, this patient will be having the non-caseous granulomatous. TB patients will be having the caseous granulomatous. And what are the other findings? And when you do the labs for this patient, on the labs, you will be seeing the hypercalcemia and hyper ACE levels due to lung damage, and also CD4 levels will be elevated. This is the only presentation CD4 levels is elevated in these patients. Okay. And what is the sudden cause of death and what is the cause of death? So sudden will be due to ventricular arrhythmias. Okay. So the ventricular sudden arrhythmias can be occurred in this patient as a sudden cause of death. But the overall cause of death is the respiratory failure due to lung fibrosis. Okay, this is what. Next, moving on to the last topic, that is your Light's criteria seen in the pleural effusion patients. Okay, in the pleural effusion patients, this will be followed. What is that Light's criteria, guys? First thing that you have to take note, pleural fluid and the serum protein should be more than 0.5. And the LDH, serum LDH and the pleural fluid LDH more than 0.6. And the pleural fluid LDH should be more than 2/3 of the normal serum limit. That is what the criteria should be done. Even if it is 1 also, then we can consider this is a exudative type of the pleural effusion. And again, the most common cause is the pneumonia. You can do the pleural tap for this patient. Pneumonia is the most common. And other causes, if any criteria is not done, then we can consider this as a transudative fluid. Next, moving on to the last one, that is your curve 65 scoring. What is the curve 65? C for confusion, U for urea more than 7, and respiratory rate more than 30 breaths per minute, and systolic blood pressure less than 90 mmHg. Curve 65, the 65 is the age. If the patient is falling in the score between 1, then you can send this patient as a OPD basis. And if the patient is having the 2 or the equal to 2, then we can consider this patient should be admitted and observed for the 24 hours. And if the patient is more than 3, then this patient need the ICU and the mechanical ventilation as a treatment of the choice. And when I say causes, the most common cause for the community acquired pneumonia is always your streptococcus pneumonia. Okay, streptococcus pneumonia is the most common cause, but the patient is having the hospital acquired. If the patient is having the hospital acquired, then the most common is the staph aureus. If the patient is having the ventilator pneumonia, that is due to your pseudomonas. Pseudomonas is the most common cause. And you can remember this one also, the one fact, the sepsis most common cause is the pneumonia only. Overall, the most common cause is the pneumonia. Okay, this is what your overall the respiratory system and the neurological system that we have discussed. Please go through these tables and please go through these criteria and please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects.